Few things to start with. What has changed for us? One is the diagnostic CTA. I think CTA has made a big difference. CT is not very good. Sometimes it can be very tricky, and I personally don't have any reservations if the registrar on call wants to get a CTA done if he's not really sure. Because if it's negative, it's fine. It's negative. It's easy to look at it. I don't care. It takes me a minute to look at it. But if you pick it up, it's great. Call us. I mean, that's what I do. But the other thing which has made a big difference for what we do now is the stent retrievers. I think that has made a big difference to how we treat. And a lot of the data from the past is all about penumbra and the old technique of penumbra. Everybody can hear that, yeah? And those things have made a big difference. So I think certain things have changed. And since 2009, Tony did quite a few before, but I think it has picked up over the last 3 years because of the stent retrievers. Because now we have a chance, we can do something different. There are loads of papers in radiology, and I think what Christine and Emma and John and everybody is, we need people, the clinicians, to really look at whether we're making a difference. Because if you ask the radiologist, I'm going to say I can open the artery, and we think, yeah, we're very sexy, we can open it up, it's great, but do we make a difference? But if you look at the paper here, if you look at this one, they've got about 18 patients here, and look at that. I mean, they have opened up. There's a very good success rate of 94% in opening the arteries. And these patients also, if you look at MRS 0 to 2, they're about 50% good outcome. Now you'll see loads of different papers and different interventionists. Like you say, if you look at, there is an interventionist, I think in Argentina, he never has a complication. He presents an interventional. We all know, everybody who, all of us who do a lot of this work, we have complications and we get into trouble. And we get into trouble, we try to blame it on the stroke physicians most of the time. But, we have problems. If you look at all this data from here, look at that, and it varies. You see the people, you can open up something around 100% here, but look at the MRS 0 to 2 is 28, but look at this study, where they've used stent retrievers. And I think stent retrievers is very important. I now don't use IATPA. Tony, do you use anymore? No, we don't use IATPA at all. I just don't. And because I think the stents do the job. And if it doesn't work with one, I'll try the other one. There are different companies which have come in and they work. And I think at the moment, and we have different experiences, but there's some very good ones. If you look at the stent retrievers, so this is the main thing, stent retrievers for us. Okay, we have stents which are solitaire and revive. So I have a favorite which is solitaire. Tony has a favorite which is revive. We keep talking about it. Yours is better or mine is better, but they do the job. And then we play around with Phenox, Trevor, and we have used them, and they all do the job. Some of them are slightly different, but they all seem to the job. And then if you look at different companies, the companies will tell you that, oh, mine is close at the top, the clot doesn't go forward, it will catch. Honestly, I don't think it really makes much of a difference. What goes up, it goes up. But everybody is different, everybody's experience is different. Now, Ahmed has already talked about this, and it's interesting because if you look at the data, in about 3 years, the number of bacillars we have done has gone up. We did about 13 cases, and we looked at the data which he has shown. We looked at the data of how they've done, and one of the important things which I'm going to show you and which Ahmed was talking about was the delayed treatments in people beyond 12 hours. That's amazing. You don't even think of trying to treat a basilar occlusion beyond 12 hours. And if you look at what, again, I was saying, there are loads of devices. We've got solitaire, we've got revive, and I think these two are pretty much what most of the people use. Penumbra was where we started. You were sucking this clot, suck the clot, just suck it up. But it doesn't work all the time, honestly, and sometimes it's really hard. But you can mix and match. And our experience as interventionists has grown. So we have got better. 2010, when I started in Leeds, the first case I did, I messed it up. I mean, it just didn't open up. But I was doing it differently than what I do now over the last 3 years. So I'm going to go with this patient first. I think Ahmed has shown you some bit about this. 41-year-old man. He had an NIHS of 35. He came in tubed. He had a CTA that showed basilar occlusion. and then he was transferred to LGI. Now, he had an angiogram, and I thought he was a good fit young man. I thought I did a good job on him. Look at the CT. CT was very classical, tense basilar. Tense basilar. There was nothing much in the CT. There was not much infarction, and the brain looked pretty good. And then I had the CTA, and I think CTA makes a big difference. If you have, if I get called from somewhere outside, and that's what we have done. If you have somebody with a basilar or somebody who needs us, you have to establish the diagnosis. You need a CTA there because you need the diagnosis. So CTA is pretty good here, and you can see the clot here. You can see the posterior cerebral artery. You can see there is no contrast in the basilar artery at all, and you can see there's a good basilar thrombosis. We went in. If you look at the left side vertebral artery, it wasn't really filling the basilar artery. It was mainly in the pica, so it wasn't contributing. The right was the mainly dominant one, as you can see. And as we come up, you can see that the right comes up here. It's taken the turn over the C1. This is the C1, C2, where the vertebral artery is, and you can see the small clot there. I worked my way up, and I continued opening it up. I opened this up. I still had a clot here. I carried on, and this is sometimes very difficult because you are going in blind vessels. It's completely. So it's all you have to think. You have to be very careful because you can rupture. And as we go up, I opened this up. I opened the whole thing, and I slowly got up into the vertebral artery, vertebral basilar junction, and there we go. And often it happens. You carry on, and suddenly you'll just get the clot. So you have to persist, and you open it up. Brilliant, I thought. But you can see that everything is not really that good. You can see the basilar very good. Sometimes you don't see these perforators, and the flow was very good. I stopped there because I thought it was fine. But he didn't do very well. And he's improving a bit, but he's not great. So I did a great job, opened the artery. The guy didn't do very well. But in the other hand, if you look at this one, so I wanted to show you my problem first because you'll think that as an interventionist, I just want to show you some good cases. But if you look at this one, he was good. He was 58, NIHS of 4, fluctuating GCS. The radiology registrar was good. He picked it up, and then he got a CTA done, which was good. And then I got called, and we had a lot of debate about this guy. He's fluctuating, GCS 14, 15, and the CTA showed a small clot. Yes, even at the end of it, I think it was Friday, so at the end of it, we decided that we're going to take him in. So we did an angiogram. You can see the left vertebral artery, the basilar artery. You can see the right side vertebral artery coming in. You got the superior cerebral artery and the clot here. Right posterior cerebral artery is okay. The left has got a clot. So you can see, and I personally, I think some of these will go off slowly, and I think we made a decision, we're going to take this clot out. And sometimes it's very difficult. Most of the basilars who come to us, they are all comatose, intubated, and you're not talking to them. When you're actually consenting a patient who has a basilar clot and he can't really talk to you also, it's quite difficult to really try and get some sense that, I can actually talk to him. And if you look at this, you can see the stent. This is the stent markers here, and you can see the stent has been placed across the clot. You can see the clot here. You can see the stent is on this side. You can see I have already opened up the other side, and boom, the clot has come out. And then you got a good flow, and everything is good. He did pretty well, and he was clinically very good. But if you look at an MR, which we did afterwards, and he was good, he did very well, you can see, but he still got small areas of hyperintensity in his both cerebellar sides, posterior cerebral arteries. So he had some infarcts, but he was asymptomatic. He did pretty good from them. So anyway, those are the infarcts here. You can see on the diffusion. Again, you can see the infarcts showing restricted diffusion. His MRA, as you would expect, because the neurologist is always going to check what I'm going to do, and I'm not worried about that, but it's pretty good, and the MRA shows that the basilar artery is open. Now, what is we've done quite a few now. We were very lucky to do some of the children. We did about 4 children now, 4 children with strokes, and that's pretty unusual. Here is a boy who got into the news and it was quite interesting. It was on Sunday night about 12 o'clock when I got called, and I stay in Manchester. So I drove from there, and the child was in Bradford at the time he was being intubated. I reached from Manchester into LGI before the child came from Bradford to LGI. It's quite interesting, and I didn't get any points also, so it was quite okay. But it was quite interesting. It was 5-year-old, and this was my first 5-year-old I think I did. And if you look at his angiogram, he had a complete occlusion of his basilar artery, and I went in from the left side and took the clot out, and he did pretty good. He did very well. He had cerebellar infarction, for which he needed neurosurgery, and they did some evacuation. Neurosurgeons weren't very happy about it in the beginning, and you have to push them. You have to, because they're also not very used to it. I've realized that you have to really push, but now they also are slowly coming around, trying to get this done. So we've now had a couple of them where they have operated, and they had to kind of relieve the pressure. So this child did very well. What was interesting, like was Ahmed was talking about, is the patient with delayed presentation, more than 12 hours. I mean, that is quite interesting when we looked at this. And Ibrahim presented that in a seminar as well. And we looked at everything. So we looked at, are we doing any difference? So as usual, everything was checked. We had any complications. So we found about 6 patients in this group, delayed presentation or delayed intervention. So we had 6 patients. Again, when we look at that, we have the earliest one was of 15 hours, and then one we had about 74 hours, which Tony did, and then I'll show you that case. It's quite interesting, and that did very well. With 3 patients, and they had again different level of obstruction. They had on the top, then they had vertebral artery occlusion, as you'd expect, and it's not a big data, but again you can look at that. You can see that 50% of them did very well. So only 6 patients, but 3 out of them, more than 12 hours, have done well. So which was quite a surprise for us. I think some of you would have probably not expected that. Now there are various theories, and everybody will talk about it. Some of the people think that some of these people do very well because of the circle of Willis, and if you got a good posterior communicating artery, you got a flow coming from the front, which is maintaining the flow on the perforators, and that's why maybe they do well. I don't know, but everybody kind of thinks differently, but it maybe that's one of the reasons why some of these patients have done well. We do need to look at the CTAs and see whether these patients had PCOMs. Now I'm going to show you 1 or 2 of the 2 cases. This was the lady which Ahmed was talking about. This lady came to LGI, so we missed it. And she came to our emergency department. We had a CT scan. The CT was seen by the registrar and the consultant, and it's hard. Some of these get easily missed. We can miss that. If you're looking at 50 scans, you can easily miss. This girl was missed. She went to America, where she developed progressive symptoms, and then CT was thought to be an artifact, but CT can be tough. And then she presents with basilar stroke. And if you look at the CT here, CT can be tough. You have a problem. Retrospectively, everybody thought there was a clot, but it's easy retrospectively. CTA, there was no doubt, and that's why one of the things when it's a trainee asking me, can I do a CTA? I know Janet might not like it there, and most of the radiographers will hate you for that, but who cares? Radiographers always hate you. So you just do a CTA because you need a CTA. You need a CTA. It's a negative. It's negative. What's the big deal? So you looked at it, and obviously I think this was Tony. You did this, didn't you? And it was difficult, and the basilar was occluded, and Tony got as much he could open up, and it's pretty much open, but it was really hard. We're talking about a few days down the line, as you can see, and we opened up, but she didn't do very well. Correct him? Did she bleed? Yeah. Okay. Now this is the interesting one, and this was a 10-year-old boy, and I remember this because I was in the better side of the world. So I was in a private hospital. Somebody called me up, and you don't want to get out of the private hospital, do you? So you just ring up your colleague and you say, when Tony was in the hospital, And this child's history was quite interesting because he presented to another hospital where he was again missed for a basilar stroke. And it was interesting because stepmother's mother was a stroke nurse in Latvia, and she rang up obviously that the child had some swallowing problems, some brainstem signs, was missed in the hospital. But the stroke nurse in Latvia, she picked it up. She said he's got basilar thrombosis. So that's where the scans were then reviewed. It was quite interesting. So she picked it up on the phone. It was and then they went back, looked at it. It looked like a basilar clot. Got an MR done, which showed obviously the stroke. The basilar artery is gone. So the diagnosis was coming from outside the country. And then obviously that was 10-year-old. It was Friday evening. Nobody wants to do anything. And we were then called. Tony was in, and he stayed back on Friday. I remember this because I was going to do it, and I got stuck for 7 hours on a motorway going towards Manchester. He finished this before I reached Manchester, so I was cursing. I could have been doing this. And but if you look at it, it's quite obvious that the basilar artery is occluded, the right vertebral artery, left vertebral artery. You can see the anterior inferior cerebellar artery, and the basilar is gone. Tony's put a stent in there and opened up, and you can see he's worked his way. He uses revive, and he's tried to open up, and there was a little bit of clot remaining. He stopped at the time. I think it was by the time quite a while.
Revive and passing too many times, picked up a solitaire to use to get the last bit of clot.
Yeah.
And the nurse dropped it on the floor, so we had no more devices to use. And because there's a vertebral dissection on the left side, the patient was heparinized. I thought that would be enough.
As you can see here.
Left with a small amount of clot left.
So but the flow was pretty good. So he stopped at the time, which is what I would have probably done the same. And then he stopped at the time. We have improved. We have more devices now because our experience has improved. We've got lots of stuff now on the table which we can use. He heparinized the child, and if you look at that, he got worse and got locked in a few days later, and his CT again showed significant brain stems changes. And like Ahmed was saying, some of this disappeared, some of this changed. And Tony brought him back, and then he opened up, and look at that. That's a brilliant result. It's got the basilar artery open. Absolutely fantastic result. How do you think this patient did? 3 days later? Anybody? Good, bad? How many people think it did well? Great. Yeah, that's it. I mean, look at that. He did brilliantly. So sometimes God is great. Sometimes we also are quite unlucky and we can be in a mess. But things he did very well. I think to conclude, intervention for basilar, I think for mechanical thrombectomies, there is a good role for that, I think. I leave it to the neurologist to sort other things out, and just let me know if you want to take the clot out. I can come in and pull the clot out. I think our techniques have improved. I think our techniques have definitely improved. We've got better imaging, and we can make a difference. Okay, thank you.